Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Welcome to the Conversations with CEI podcast. On today's episode, we'll learn about the intersection of chronic pain and substance use disorders from Dr. Linda Wang, the medical director of CEI's Hepatitis C and Drug User Health Center, and Dr. Lauren Kelly, a geriatrician and palliative care provider at Mount Sinai.
Hi, Lauren. Good morning. How are you doing today?
I'm doing great, Linda. How are you?
Good. Thank you so much for joining me. I think in today's episode, we're going to spend a little bit of time talking about the intersection of chronic pain and substance use disorder in the care that we provide for our patients. And we want to keep it rooted in real clinical cases that have impacted both of us in our practice, but also highlight some of the challenges which can be rooted also in policy and just outdated thinking about how we care for these complex patients. So thanks for joining me. Would you be able to introduce yourself briefly, your name, where you work, your affiliation, anything that would be relevant for this conversation?
Yeah, absolutely. So my name is Lauren Kelly. I am a geriatrician and a palliative care doctor at Mount Sinai. I also practice primary care with you at the REACH program. And I have a special interest in substance use disorders and how they intersect with chronic pain. So this is, I think, a very appropriate conversation for us to be having.
Amazing. Thank you. So maybe I can start off by sharing a recent case that I have been working on, and we can go from there. And I'd love to also hear your thoughts and any questions that might come up. So I, over the past year, have been taking care of a 62-year-old woman who has a very remote history of opioid use disorder. She had in the 1980s, so over 40 years ago, was using heroin pretty regularly. And then through treatment, ended up stopping heroin and for many, many years. And she was doing fine. She lived upstate. She was really happy in her life and was very productive. And in 2019, she began experiencing some symptoms, namely this tingling sensation in her body, what she described as jolts of electricity in her head, pins and needles, sensation in her face, neck, and shoulders, and subsequently went to meet with a variety of specialists, namely neurologists, to try to understand a little bit more about what was going on in her body. She also saw some integrative medicine specialists. She tried many different treatments for, at the time, she didn't have a diagnosis, but she was being told, like, maybe this is a chronic infection of some kind. It was not. The treatments didn't help. She has tried all different kinds of medications for pain, namely non-opioid medications that were prescribed to her by the neurologist. She had gotten special nerve testing done, which were, at the time, a little inconclusive of a diagnosis. And then she was getting frustrated. Her pain wasn't getting treated appropriately. And then she started using heroin again because that was the only thing that she remembered would help with her pain. She's absolutely frightened starting this because she was obviously very worried about potentially having a negative consequence of using heroin. She was worried about the fentanyl contamination, but that was the only thing that was helping with her pain. She began taking the heroin that she purchased in local drug checking programs because she was so concerned about fentanyl. She wanted to make sure that whatever she was using was heroin and not fentanyl, didn't have any other fillers inside. And eventually she wanted to get medication prescribed to her. And specifically, she wanted opioid pain medication prescribed to her to help treat her pain because that was the only thing that worked for her. And she did not want to continue using heroin. She was not using in a way that we would consider to be consistent with opioid use disorder. She was really using it to self-treat her pain. And so she found herself going to an opioid treatment program, which I think she had not been to in many decades, right? To get methadone, because in this country, in this state, one of the only ways you could get methadone is through an opioid treatment program. But that is primarily for individuals who have opioid use disorder, which I think I would argue for this individual, she did not have that currently. She had chronic pain. But the reason she went to the opioid treatment program is because she felt like no other prescriber would feel comfortable prescribing methadone to her for chronic pain, even though it is legal to do so at a federal level and at the state level to prescribe methadone for chronic pain. But given her history of opioid use disorder, I think that tends to cause some clinicians to pause. And she had had negative experiences with clinicians when she was seeking care before in the past. So she goes to the OTP, opioid treatment program, and they enroll her in methadone. And she's getting some methadone. But unfortunately, at most opioid treatment programs, the methadone administration is really only done once a day, which is not adequate for pain control. And it was not the right clinical environment for her to be getting this kind of care. Thankfully, the provider at the opioid treatment program recommended that she come to us at the REACH program to see if there was anything we could do to help her. And so she comes to me with this history, clearly with some of these concerns about whether or not we would be able to help her. And after a review of her history, it seemed mostly clear that this was an individual who had been dealing with a lot of chronic pain that later was felt to be consistent with small fiber neuropathy, which was very difficult to treat with some of the non-opioid medications that she's already tried. And so we decided to try her on methadone that I would prescribe for chronic pain. And then we later added a second shorter acting opioid pain medication to help with some of those breakthrough moments. But I want to pause here because I think I've shared a lot about this particular patient's backstory. But this is not an uncommon situation that we encounter. And I think, especially given your expertise that you encounter, right? Getting referrals for patients who might have both chronic pain and opioid use disorder, whether or not that opioid use disorder is active or remote in the past, this presents a challenge for clinicians. Like, what do you do when someone comes to you with chronic pain, but a history of opioid use disorder? What can we do for them? Can we prescribe them opioids? How do we do that safely? What are the options to consider?
Yeah, absolutely. And so much comes up just hearing you talk about this patient's case. When you have a diagnosis of opioid use disorder, regardless of how remote it is, it's almost like you carry it as a passenger your whole life. And there's a lot of internalized stigma around that. There's a lot of worry that I've heard patients express around, let's say that they're in recovery, around having to restart opioid therapy. Like, does this mean I'm back at it again? What if they've taken so much pride in their recovery? So that's something that I see a lot. And I also see patients just feeling like they're ramming up against a wall, like they're saying they have pain, they're trying to talk to their doctors, and they're just being shut out repeatedly. And so it feels like they're kind of pounding the pavement and trying to get their stuff. Like it's almost like the way that we hear patients and respond to patients really perpetuates a lot of stigma. And it's not a therapeutic relationship often, I think. So just being really mindful about, I think about when I'm actually interviewing a patient and getting a history of their relationship to their substance use. I think that's so crucial. And I don't think we do it systematically when we're meeting patients, because we worry, oh, if I ask about their substance use, they're going to think that I'm judging them, or it's going to disrupt the rapport. But actually, it's critical information. And if you ask it with non-judgment, you can really learn a lot about how people are relating to substances. And in the case of your patient, it sounds like she was really dealing with pain. The active issue was chronic pain and not necessarily craving for a euphoric experience of a substance. So that's when I think about treatments for pain. And when we're thinking about treatments for opioid use disorder, methadone, buprenorphine, and certainly the restrictive nature of methadone prescribing in this country, there's a question of, can I do this from a legal perspective? Oh, this person has a history of an opioid use disorder. Can I prescribe them methadone? And if this was a patient I was meeting, and I remember talking with you about this patient when she presented, I think methadone for pain indication is appropriate in this situation. Her opioid use disorder is remote. The patient seems like she's functioning. I mean, maybe having some functional challenges related to her pain syndrome, but we define opioid use disorder, we define addiction on the basis of, is this causing dysfunction or problems in the person's life? And by all accounts, this person was doing very well in her life and had done beautifully in recovery. And the pain was really the story. So I think just kind of trying to parse out what's going on in the first encounter with someone is really important. That's not to say people that have active use disorder don't deserve medication for pain. I think that's also something that makes some people very uncomfortable. Now, I see a lot of patients in my practice who come to me who have either chronic pain or who have an acute on chronic or who have a new acute cause of their pain, such as a cancer. And that's a lot of patients who I see actually. And again, it's important to understand how they're using substances, what things are coming up for them. Or did they overdose last month and have a hospitalization for that? Or are they kind of more stably, chronically using substances in a non-chaotic way? And then here all of a sudden, cancer comes along and really just messes everything up and things become very dysfunctional related to that. And the question of what's their interest and or motivation around their health, and like what is their interest and motivation around how they're using potentially dangerous substances, and how can we make the situation safer for them, is really kind of how I think about it. So if patients are interested in medications for opioid use disorder, that's great. That's a really great starting point. And I love to hear that, because I think there's order and organization and safety in that, having some level of control. Where if someone is open to going a methadone treatment program, that's great. We can enroll them in a program. We can get them started on a dose. We can often work collaboratively with opioid treatment program directors to split doses for patients that have severe pain. We can often work on increasing the amount of take-home medications that patients can get if they have functional impairment, mobility impairment related to their illness, related to their pain syndrome, perhaps. So there's definitely a lot more flexibility around that with methadone these days. And then buprenorphine, of course, being able to prescribe that in an office-based setting, that also is much more convenient for patients. And so we use that whenever we can as a base. And then if there's additional pain that's breaking through that, regardless of whether an opioid use disorder is active, or particularly if it's more active because they're in pain, then it makes a lot of sense to think about an additional as needed medication, opioid medication for breakthrough pain. Now, this is all to say that opioids are not the end all be all for pain treatment. I just want to drop that in there to say there's a lot of other medications that we use and other therapies that we use that are non-pharmacologic that really can work wonders for folks with pains. I think it's really important to also highlight some of the non-pharmacologic options for pain treatment. We know that pain is an experience of the mind, the body, the spirit, sort of the whole person. And really trying to approach it holistically is, I think, the recipe for success. So a lot of my patients, in addition to prescribing medication, I'm also talking to them about things like physical therapy, which fortunately most insurances cover, albeit in spurts. And they will kick people off of physical therapy who are continuing to benefit from it. So just increasing access to physical therapy, good physical therapy ideally, and targeted for the patient's problem. And also there's other treatments like acupuncture, which has a pretty large body of evidence at this point that it can be helpful for things like chronic pain. It's not something that the insurance companies are paying for, really. Some commercial plans, occasionally Medicare plans, will cover some portion of it, and the patient is responsible for copays, which can sometimes be very high. It's not available to patients who have state insurance because it's usually prohibitively expensive. It can be close to $1,000, if not more, for a course of acupuncture therapy. It's often 6 sessions, if not more, to see a benefit. So this modality that we know is very helpful. It's sparing opioids in many cases. It's just not easy for folks to access. So that should change. Insurance should be looking to cover this more readily if they really have an interest in the opioid epidemic. Other treatments, TENS systems, electrical stimulation for pain. There's a modality called scrambler therapy, very, very expensive, but with a lot of good early promising data. So I think that there's a lot that we have to learn about pain and treating pain that doesn't necessarily involve opioids.
And then you and I have talked about pain reprocessing therapy, right, Lauren?
Mm-hmm. Yeah. The psychological aspect of pain it can't be overstated. We think about depression as a pain facilitator, anxiety as a pain facilitator. It's really a loop that spins around and round. And if you can treat mental health conditions, that's crucial as part of the pain. The reprocessing therapy, mirror therapy, there's a lot of different interesting psychological approaches, behavioral approaches to pain that we don't have access to because A, nobody around here does it, or B, they do it, but they can only do it with a certain population, as is the case for our hypnosis program. Or there's a group that does hypnosis for patients in our health system, but it's specifically for patients with breast cancer. But I think that would be tremendous to be able to offer those types of modalities to patients outside of the oncology space in the general population. You just need people to do it, and you need a health system to prioritize these types of treatments.
We've been talking a lot about stigma and how that is a significant barrier for patients with chronic pain and SUD getting the care they need, getting the medications that they need. And I think we've identified that obviously stigma occurs at many different levels. It occurs in internalized and personal level. It occurs at an interpersonal level, and it occurs at the system level, right? And there are many different systems that potentially could perpetuate stigma. So I'm curious if you have seen examples of that and if you have any highlights that you want to share.
Yeah, in advance of our conversation, I was just perusing the internet and found the rules and regulations on controlled substances in New York State. And this is unfortunately the most up-to-date guidance that the state has released. There is a section of that document called Dispensing to Addicts and Habitual Users and Treatment Programs. And this is where they outline that who controlled substances can be administered to. So I'm reading from the document. Controlled substances may be administered to narcotic addicts or habitual users of controlled substances upon the order of a person authorized by law to practice medicine. So the people that they include in this as being rightful recipients of controlled substances are, number one, bona fide patients suffering from disease known to be incurable, such as cancer, advanced tuberculosis, and other diseases well recognized as coming from within this class. 2, for addicts who are aged and infirm or severely ill, and it is determined that withdrawal of controlled substances would be dangerous to life. 3, to relieve acute withdrawal symptoms. 4, for detoxification of an addict participating in authorized treatment program approved pursuant to Article 23 of the Mental Health Hygiene Law. And then 5, for addicts participating in an authorized methadone or other controlled substance maintenance program. So that is the list of people that our state thinks should be prescribed controlled substances if they have a history of addiction. It doesn't say anywhere in there people living with addiction who have chronic pain. So this is an area of gap. And I think that we need to write updated guidance on this. And we need to really spread the word that, patients who have severe pain that warrants the use of opioids should be able to access those medications. It's clear that this was the rule of the land 10 years ago, and it's just not really trickled down that patients should be able to access these medications. So I think that's just one example of a system level, something that perpetuates stigma at the system level is the guidance from our own government. So we need to adjust that.
Absolutely. And it reminds me that we continually receive informational messages from our government agencies recommending that we not prescribe opioids for pain, but are given very little guidance about how to manage these difficult situations, which do involve opioid pain medications. We can't just magically wish it away. It's here. We need to figure out what to do about it. And there's lots of individuals who are suffering out there, right? I'm reminded of all of the pain advocacy groups that worked really tirelessly also to update the CDC guidelines about safer opioid prescribing after the 2016 guidelines came out and really nudged that pendulum all the way over to the other end without any room or space for any flexibility. And so I think we're all thirsty and really waiting for more nuanced guidance to help us figure out how to deal with these complex situations on the ground in a practical way that also acknowledges and invites the patient into the room as an expert on their own pain experience and their own physical well-being. So the approach that you described about offering opioid pain medication for the patient I described, because she has a very remote history of OUD and pain is really front and center for her. And then the patients that you alluded to who might have active substance use or opioid use disorder, they might have cancer that warrants opioid pain medication. Like these are all approaches that make a lot of sense to me, but they're not things that I see other providers really taking upon themselves. And I wonder about that because it's not different from the standard of care that we provide other patients. You had already mentioned and reiterated to our audience that it is legal for us to offer these approaches, to prescribe methadone to patients who have chronic pain, and then also to offer both medications for opioid use disorder plus another layer of opioid pain medication for severe pain, whether it's because of cancer or another serious illness. So why are we experiencing so much hesitation and just, in my mind, a disregard for the kind of standard quality care that people really deserve?
Yeah, I think you can say a lot to this topic yourself. My thought on it is that it's stigma and it's an avoidance of difficult conversations. It's wanting to maintain the status quo. It's hearing from other people that patients with substance use disorder have behavioral issues and not wanting to invite that into the clinic space. Or there's just so much talk about what it means to care for people with substance use disorder. And guess what? The people who are perpetuating all these statements are people that don't take care of patients with substance use disorders. So I know you and I do this all the time and we love it. And we are passionate about what we do because we see people when they come in. We don't see a diagnosis. We don't judge the patients when they come in. Sometimes we have really difficult conversations with people, but there's really a great satisfaction in that for me. I mean, I also went into palliative care. There's not a lot of easy conversations there either. So I think it's just really getting to the bottom of the tough stuff and showing compassion and care and recognizing that our patients are people and they're sons and daughters, they're moms and dads, they have kids, they're trying to care for other people. Perhaps they're caregivers as well. Perhaps they're dealing with a lot on their plate from a psychosocial perspective, right? Unstable housing, incarceration. I think it's just tremendous what they can go through. And so just having empathy and realizing that no one wants to have a substance use disorder and people are working really hard to try to maintain stability in their lives. And there's a lot that we can do as providers to support them in that.
Yeah, I definitely agree with that. It's clear that stigma is really a major player in all of the barriers that we see for patients with chronic pain and substance use disorder. But I also feel that sometimes I don't love doing all of this, right? Like, I think the reality on the ground is that it's hard. You know, we're not allotted a lot of time in our office visit follow-ups, right? I think like sometimes we want and need a conversation with a patient that should last 60 minutes, but the only amount of time we're allotted is 20 minutes. And on top of that, there are innumerable burdens that I think we as a health system place upon providers and other clinicians want to start prescribing opioid pain medications because it's indicated, right? So there's different checkpoints, there's prior authorizations that we have to obtain from the insurance. For New York State Medicaid, if you want to prescribe an opioid pain medication, you need to obtain a prior authorization every 3 months. And on top of that, we see on a regular basis shortages of certain medications and doses. We see pharmacies informing us that they've reached their quota of chronic pain patients, whatever that means. We see pharmacies telling us that their distributor is no longer selling them enough opioids to meet the needs of all of the patients that they service who might be on chronic pain. So there's a lot of these issues that come up month to month, and sometimes it feels exhausting to have to do this time and time again. So on the one hand, I do really enjoy taking care of this patient population, but I also am increasingly feeling burnt out doing this kind of work. So I'm curious if you are able to share your thoughts about that, and also maybe what are some of the things that we can do to just make it easier?
Absolutely. There are so many barriers, and I think you highlighted many of them. So access is a huge, huge issue. And medication access right now, we're seeing these caps that are really driven by lawsuits related to the opioid epidemic. And it's hard to go back on that because there were agreements that were reached. It varies by the state, but really there's so many players. Like you mentioned, distributors, manufacturers. There's also the pharmacists at the level of the pharmacists who feel very implicated in the decision to hand someone an opioid prescription with their license behind it. So, and then they can be prosecuted if they miss diversion, for example. So they're anxious and nervous. Everybody's anxious and nervous about the sticks, right? They don't want to be sued. They don't want to lose their license. So there's just a lot of chaos that's been created. And we talk about the pendulum swing from when pain was the fifth vital sign and opioids were flying out the door to the situation now where I can't get my patient with cancer pain 90 tablets of Dilaudid 8 milligram because nobody has it. So it's gone too far, for sure. We need to pull it back and figure out how can we maintain access to these medications, these very important, very effective medications for pain. They're risky, but we prescribe them with a lot of safeguards. We need to have conversations with DAs. We need to have conversations with the Greater Hospital Association. We need to have conversations with pharmacy leadership to work this out. It's definitely at the system level at this point that we're going to need solutions, because my calling 4 or 5 different pharmacies to access my patient's medication on top of having to do a prior authorization for that medication, which can take on the order of 15 to 30 minutes, plus the wait time and additional documentation that you might need to furnish. So yeah, this adds up. And it's really hard to do as an individual provider. If you are fortunate to have a team that can help you do these things, it makes things a lot better. But believe me, the nurses that I work with on my supportive oncology team, they're not excited about having to be on the phone and wait interminably when they can be calling patients or seeing patients and assessing their symptoms. It's work that people who are trained in medicine should not have to do. It's administrative nonsense. And I understand there needs to be some level of bureaucracy to ensure that these medications are not being prescribed willy-nilly, but we need support as clinicians to be able to get approval for those medications, to be able to find them in pharmacies. So really, it's a matter of support, and health systems need to prioritize building teams to support this work. And I'm very fortunate to be working in within the oncology practice where there's funding to support a large team. We have a number of nurses that we work with. We have a pharmacist who's part-time with us, who has pharmacy students who love to do this work and to help us. So I feel very lucky, but a lot of people don't have those robust teams. and have to do all of this work themselves, like you and I in our primary care practice, where we don't have that extra support. So I'm actually seeing both ends of it, where I'm seeing how things go in supportive onc, and then I'm seeing how things go in primary care. It's quite a different story where we don't have that same level of support. So it's really hard to put this on primary care without giving them the resources that they need and helping guarantee access more systematically.
Yeah. And I think up until now, we've primarily been talking, when we say opioid pain medication, and we're primarily talking about full agonist opioids, right? Which are Schedule 2 under the DEA schedule system. You can't put refills on it. You have to send it month by month. And as a full agonist, the more you take, the more effect you get. So the safety profile is not as optimal as maybe some other opioids out there. And so I just want to take a moment to talk a little bit about buprenorphine for chronic pain, because buprenorphine is a Schedule 3, right? We use it a lot for opioid use disorder, but it is also indicated for chronic pain in certain formulations, the weekly transdermal patch and also the buccal film. And it's also additionally used off-label in the buprenorphine naloxone co-formulation version, which we primarily use for opioid use disorder. So what about buprenorphine for chronic pain? It is not something that we see commonly done. Folks seem hesitant, even if they are pain management providers, and are seemingly very comfortable with recommending other full agonist opioids. And I think it's largely seen still as an addiction medication, right? Even though across the world, it is used commonly as a pain medication. And also notably in research labs in the US, it is used to treat pain in rats and mice. Just an interesting tidbit, but we don't use it in practice for our human patients at all. Lauren, what is that about? And how can we turn the tide a little bit to encourage more providers to take on buprenorphine for chronic pain?
Yeah, I'm laughing because my cat was prescribed buprenorphine after the procedure to remove her lady bits. It's used commonly in veterinary medicine, in fact. So it's an interesting point. There's been a lot of movement on this. So the VA actually is using buprenorphine as a first-line opioid. Now we're seeing a lot more of that. And the truth is, buprenorphine, like you said, it was a pain medication before it was a medication used for OUD. It's a very effective pain medication. And it's much safer. It has a ceiling on respiratory depression. It is not as euphoric. It is easier, I think, to taper people off of gradually over time compared to other opiates because of its long half-life. And it comes in all of these different forms. You can really do a lot of shared decision-making with patients around how they want to take it, if they want it in a patch, if they want it in a film, if they're on higher doses of opioids, doing it sublingually. So it's very effective for pain. And I tend to reach for it quite often when I'm starting someone on opioid therapy, particularly in patients who have not tolerated full agonists as well, maybe had a lot of side effects related to opioids like somnolence, sleepiness, or constipation that's been severe, or sometimes just a kind of fogginess that people describe having, like a cognitive effect. So patients who want to avoid full agonist opioid side effects, we definitely will reach for either a Butrans patch, the generic as well, or the buccal films of buprenorphine. And it's wonderful. They can be very effective for pain. And in terms of getting those medications for people, there can be challenges for patients with Medicare insurance. I find most often there's sometimes large copays for those medications. They are, I don't know if it has to do with them still being patented in some capacity, but they remain expensive. And I think that would be really helpful to drive the costs down of these medications, maybe adjusting the tier of the medication, like on the formulary of these insurance companies. And then sometimes it's hard to access sublingual buprenorphine as well. I believe you were just telling me recently about a patient that has Medicare insurance who is being asked to pay quite a lot of money per month for the sublingual buprenorphine. So there's definitely some access barriers, but it's very effective as a medication for chronic pain. It's definitely a lot safer. And so we really should be using it a whole lot more.
Yeah. And to that point about access and Medicare, I think that's a huge issue, the level of copays. But also for Medicaid, right? Our patients with Medicaid, to prescribe buprenorphine formulations that are FDA approved for chronic pain, we still need a prior authorization, even though buprenorphine, naloxone, and other buprenorphine formulations for opioid use disorder are readily covered by New York State Medicaid without a prior authorization. The chronic pain piece does feel a little more challenging, and that should definitely be changed to encourage more providers to use it more readily.
Medicaid, if you're listening, we really want to use buprenorphine. I will put a plug in for your success, Linda, with getting Medicaid to increase the 3-month renewal of prior authorization to a year when patients are on medications for 365 days. Linda has worked with Medicaid to help us do PAs less often. We only have to do them once a year. We can get an exemption I guess we might have to call Medicaid and talk to them on the phone about it. But it really should be easier. And I think you and I are both continuing conversations around that to try to loosen those regulations a little bit more.
Yeah, I love hearing that the VA has made buprenorphine its first-line opioid. I think that's the way to go in terms of recommending more uptake, to just really say, like, this is our preferred first-line opioid. It's got the best safety profile, right? And to be honest, I would much prefer people do that rather than some of the other opioids out there on the market, including tramadol, which we all wish that
tramadol
stop prescribing. But okay, I just want to highlight one other sticking point that I sometimes encounter in my patients who I'm trying to recommend buprenorphine for, is that some people may not feel comfortable switching from their full agonist opioid to buprenorphine. Maybe they feel very comfortable on their full agonist opioid and maybe they don't see what the issue is to continue taking their full agonist opioid for years and years and years. And to your point, Lauren, like, they don't have somnolence, they don't have other negative side effects of their full agonist opioid. So they don't want to switch to buprenorphine for that reason. Or maybe they don't want to switch because they're concerned about stigma, right? Being stigmatized for being on buprenorphine. And even now, like, when we try to use some of the more potent buprenorphine formulations, which are really only available in the sublingual, like, combination formulation with buprenorphine naloxone, we're technically using it off-label if we're using it for chronic pain. So I'd love to hear a little bit about maybe how you have those conversations with your patients. Obviously, we want to go at this from a patient-centered approach, but sometimes as a provider, I really truly feel that I'm worried about my patient on a full agonist opioid and trying to encourage them to just give it a try, give buprenorphine a try.
Yeah, so it's interesting to think about patients who are on opioid therapies kind of in different bins, like in different categories. There's the patient that maybe I haven't been caring for until very recently when I inherited them from another provider. They've been on chronic opioids for 25 years, for example. I think that's a different situation than a patient who maybe had a surgical procedure and has kind of been lingering on opioids for a while since that procedure. You have patients who maybe have severe acute cause for pain that maybe also. So just trying to think about, what is the person's relationship to the medication? How long have they been on it? What are, if any, are harms that have come up over time related to the medication? I do think boundary setting around opioid prescribing is really important to discuss before you start the opioid. So when I have kind of fresh starts with patients on medication where I'm the one that's initiating the opioid, I realize this is a train that we're getting on. And patients sometimes express fear about that as well. And we talk through it. We're doing this with a lot of safety. We're gonna check your urine when you come to the clinic to establish care, just to make sure that there's not substances in the body that are going to interact with the medications I'm prescribing. This is for safety. We're always going to come up with a plan no matter what. I'm going to start this medication for you, but I'm going to monitor things every month. I'm going to ask you questions like, how is it going with your medication? Are you taking it even if you don't have pain? Do you take it just sometimes to feel a particular way? Are you having issues with control around how you're taking the medication? Do you feel like your life revolves around taking this medication? So just giving them the framework of how I think about these meds and how we're going to monitor them while they're on the medication. And I also tell them, hey, these medications can help you get through a difficult time with pain, but that they're not medications we really want you to be on for forever. Some people do need to be on them chronically in a long-term way, but the goal is to taper when the medication is not needed. And so I tell them that ahead of time, because I find that setting expectations before you start makes it a lot easier to de-escalate a medication. So all of that just to say that there's different kind of flavors of this conversation. There's someone who's been on it for 30 years. There's someone who maybe wants to be off of it and really wants you to help. And sometimes buprenorphine in both of those cases can really help us. So you did mention that some patients have a lot of reluctance around buprenorphine, and that can look like different things. So just being curious about, hey, what was your experience with buprenorphine? Oh, my partner was on it for opioid use disorder and they didn't like it. Or maybe the patient themselves tried the medication when they just used a bag of fentanyl like the day before, and they go into precipitated withdrawal. They feel awful. They have withdrawal symptoms. So how did they use it? What's their understanding of it? And then also they need to be provided with a little bit of education. Buprenorphine, yes, it's used for substance use disorder, and the same can be said for methadone, but these are really powerful and effective medications for pain. And it helps to share your experience as a provider with your patient. Hey, I've had other patients, or my colleagues and I have a lot of patients that are doing really well on buprenorphine for pain. It's safer. You kind of want to sell it for all of the good qualities that it has, and then kind of see where the conversation lands after you've heard from them, like what their experience is. So I think it's definitely a shared decision. If someone is doing really well, functioning in a great way, they're using their opioids very safely, I'm less inclined to nudge them to transition to buprenorphine. However, if they're motivated, they want to come off, or they're having some side effects, we do know that chronic opioid use does have some long-term effects on the body. So a lot of which are hormonal. There's a lot of evidence that if patients are going through surgeries and things like that, there can be impaired immune system, there can be impaired healing, and opioids can increase the length of stay. People that are going into procedures. I actually have a patient who I'm thinking about transitioning to buprenorphine because he's on a long and short-acting morphine regimen for chronic pain related to spinal stenosis. He's really hoping to get a fusion procedure of the spine, and the orthopedic surgeon he's working with will not perform surgery on him unless he's off of opioids or on a significantly reduced opioid regimen. And I kind of went down the rabbit hole into the literature on this, but there is a lot of data around folks that are on high doses of opioids preoperatively, that there's increased complications, that there's increased rates of infection, there's impaired wound healing, longer rehabilitation. So higher pain requirements, not surprisingly, after the surgery. So I think there's good reason to kind of to bridge someone over to buprenorphine in that situation too, especially if they're very motivated to surgery and you want to just collaborate with other providers. At the end of the day, like even if you disagree about a management strategy, I think it really helps to build relationships and to collaborate with providers. And so I'd be happy to switch this person over to buprenorphine if the patient's willing. So those are some of the examples. I do think it's challenging when patients who have a history of OUD who maybe would be great candidates for buprenorphine decline it because they've heard or if they've had personal experiences that have been unpleasant. That I think you need to build a relationship with the patient, develop rapport so that there's some level of trust and comfort to be able to maybe give it another try. But it doesn't always work out. And sometimes we need methadone, and sometimes we need to use full agonists in a safe manner. So it really depends on the situation.
I love the way you approached that last comment, Lauren, and describing all of the potential conversations for all the various scenarios that might crop up. I think that was really helpful. And just to circle back to the case that I brought up in the very beginning, I did offer buprenorphine to that patient who declined for a variety of reasons. But I think the main concern was that he was worried it would not be efficacious for her pain, even though it would have been indicated. And I think a lot of that had to do with her trying methadone and feeling like methadone really worked for her kind of neuropathic pain and wanted to stick with it and find the right dose. And so currently she's doing pretty well on methadone, a combination of methadone and hydromorphone. And seeing me in the office every 2 to 3 months. And I think that it's as optimal as we will ever get it. And then I think what I see in the next 6 to 12 months is just us trying to navigate the field of pharmacy limitations, stockage, distributor, like all of these other barriers that present a challenge for our patients in accessing their opioids. And at some point, we may hit a crossroads where we need to rediscuss buprenorphine because we aren't seeing the same limitations in access with buprenorphine right now as we are seeing with other Schedule II full agonist opioids.
While you were talking, I was just thinking about a patient who lives out in Long Island and is on hydromorphone for cancer-related pain. And we're actually switching, this was last week, we're switching him to buccal buprenorphine because he can't access hydromorphone in Long Island, way out there. Yeah, so it definitely is another angle to help patients see why buprenorphine can be really beneficial. It's easier to access.
Thank you so much for joining me today and talking about this really complex, but also very critically important issue that all of us are facing today as we try to care for our patients who have substance use disorder and chronic pain. I think obviously there's a lot of challenges that we need to continue addressing, but I think hopefully we've shared a few approaches and stories that might be helpful for other folks who are listening in. And I think that the journey and the practice continue, right? There's still a lot of things that we need to do for this group, and there's a lot of ways that we can optimize this care.
Thank you for having me on.
Thanks for listening. To learn more about ways to manage chronic pain and substance use disorders, please visit us at ceitraining.org to access our free accredited on-demand trainings or click the linked resources below.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.